All right. Good morning. This is John Delossantos, President and CEO of JMD Healthcare Solutions. And today we're going to be doing a relatively quick, maybe more of a review for a process that I think most of us are used to, the triple check process. But a little spin on this one, a little PDPM engraved in this. So you guys will have an opportunity to look at this new way of doing it. With COVID and everything, we've really probably gotten away from this. Staffing, it makes it hard to do, but triple check is an important process. There's a reason for it that people probably don't know about, but we're going to be covering that as well. So it's more getting back to the basics, more what we used to do. Again, this one be pretty easy compared to the other ones we've been doing. They've been pretty intense and pretty long. So we'll keep this one to an hour. Hopefully you guys get some good use out of it. And we actually have some pretty good resources at the end that you can use for your own triple check process, especially under this new payment model, PDPM. So, all right. But when we get started here, let me tell you a little bit more about myself. Again, my name is John Delossantos. I am a registered occupational therapist. I do have my MBA in healthcare administration. I'm a certified resident assessment coordinator through APACN, and I am a former vice president for the largest contract therapy company in the country. I was a 15-year veteran as the VP of that company. I've been in this industry for 22 years. Also, I serve on the advisory board for 2 colleges here in Indiana, where I live. I am an OIG approved auditor for both RAC audits and regulatory compliance audits, working with the IRO groups of corporate integrity agreements, making sure that we are being validated for all the claims that they're submitting. And I've overseen over 40 regional managers and 2,000 skilled therapists. So, I've been around this industry for a long time. I've seen the changes. I understand what they are, and I understand how we can best safeguard ourselves to get paid for every penny we deserve for the great stuff we do for our residents. Now, a little bit more about JMD Healthcare. We offer a great, it's called our RAM service. It is it's a management model to help you run your own in-house programs. It's turning out to be very valuable, and it's done by our RAM manager, who is an experienced therapist, who is a resident assessment coordinator themselves, who is trained in ICD-10 coding, CDC, infection control, take specialized leadership training, and even has to pass our specialized exam. So this person's a very valuable person who can cover both therapy operations and the MDS, turning out to be a very valuable service, putting all those things together, giving your facility the ability to bring your in-house model, but still have managed at a regional level, just like you would with a contract therapy company. So bring over all those very, very valuable tools. Very low ratio to facility, because we do help cover the MDS and the therapy services. So we can give you the attention that requires to be an MDS expert, and going through all those, it definitely is time consuming. Obviously doing some training, clinical trainings, doing your recruiting, doing all those important, holding people accountable for, there is something to say about efficiency and productivity. It is important in our industry, and it is important in any industry, quite honestly. So making sure your departments stay efficient, bringing all those great tools. So something to think about, just what we offer. If you're ever interested in that, give us a call, 1-800-PDPM-PRO or www.pdpmpro. All right, and that's it. We're going to go moving on. This isn't a commercial. I just want to tell you what we do. So anyway, we break our down into objectives and sessions, because we use this on our training tools that you will have access to if you're a client of ours, to go back and you can check one of these sections. If you don't want to watch the whole thing, you can just check in with one of these sections and brush up on a few of the topics that I covered. And in section 1, we're going to do the background triple check. What's it about? People probably don't even know what it's about, really. They think, well, it's something to check our claims. Yeah, well, kind of, but there's a reason for it. The when and the why, okay? Then we're going to review the best practices of that internal audit for those claims. How, what's the best way to do this? How do we do it? Do we, before we submit, after we submit, do you use the UBO4? Do we not? So how we do that? Why do we do that? How to decrease those potential errors. There's some really easy things that you guys got to remember right off the bat that can be a devastating problem, and very, very easy to fix. So cover a few of the hints on how to do that. In our second section, we're going to be talking about the process. What is the process of this triple check? When we say we're going to do it, what does that even mean? Some people haven't done this in a while, or some people haven't done it at all. We've had a lot of turnover in our industry. This is very important. And I'm telling you, there's some audits coming down the road. We all know that. All right. What are the key roles of the interdisciplinary team? What are the key players in this whole triple check process? Okay. And then we're going to review those responsibilities and what they're going to do. And how do we make this efficient and effective? You know, a lot of people say, oh man, we can't do it, man. It's just, we're too busy. We don't have enough staff. It takes too long. It's just, you know, it's not an efficient process for us. How do we do this efficiently? You know, that is key. You know, here we go. There's that word, efficiency, productivity, comes up all the time. It's a real thing. It's a real thing you got to think about in any industry. It's a real thing you got to think about even when you're doing these meetings and when you're doing triple check. All right. Then in the last section, we're going to review the claim process. We're going to review the data collection of the billing items that we're going to look at. Then we're going to review the data collection of the clinical items. And then we're even going to cover a little bit, because this is all going to be mostly about PDPM, like I said in the beginning, a little bit even about the Part B claims and how you could integrate some of this same process in reviewing some of your Part B claims, which are critical, by the way, and highly scrutinized just as much as the A's, if not more, believe it or not. All right, so here we go with the first section, the background of triple check, the win. All right, CMS, external MAC audits, and the OIG focus has been on rehabilitative since the start of PPS, way back in the end of 2000, right? Most recent actions have focused on the rehabilitative service delivery and appropriateness. Is what we're doing, is it skilled? Is it something we should be doing? Or is it something that we're doing that anyone could be doing? So the validity of those claims, is that a skilled service or not? You know, remember, under RUGs, that was even more important because it dictated the entire payment, basically. Days, minutes, that was it. That's all that really mattered. PDPM is a little different, but that does not mean therapy is no longer important, because it is. And it does not mean there's not requirements, because there still are. All right. Settlements in this area have been significant. I'm talking millions of dollars. And a lot of providers get in big trouble. And most of the CIA things have been for therapy, or for inappropriate delivery of therapy minutes and treatments. Okay. Specific and all regulatory requirements must be met. Okay. Or the claims are at risk and may be denied. So this came out pre-PDPM, but it still applies. That's why I left it in here. It's not like it didn't change anything. Okay. It still applies today, right? Even though it was before PDPM, you think about those phrases, you think about those ideas, they're still valid. Remember, regulatory items didn't change, only the payment model. Now, why? The Medicare Provider Agreement requires providers to bill accurately and be compliant with regulations, whether Medicare or any other external agencies audit you or not. Providers are required to implement measures to report errors, correct errors, and educate on the prevention of more errors, right? You have a duty as a provider to make sure you have a way to ensure your claims are legitimate and your claims are validated. It is your responsibility. It is not the responsibility of the state to come in. It's not the responsibility of an auditing team to come in. It's not the responsibility just for Medicare to deny it or review it or send an ADR request or whatever it may be. It is your responsibility to have something in place that ensures that accuracy. And if you don't have that, this could come back on you even bigger than a few denials, okay? That's why this is in place. That's why this is a great thing. And guess what? It's better to be in front of the denial issue than behind it. You think you're short-staffed now? Wait till you have 40 claims, every month to send into Medicare, and you have to hire a whole team to do this. It's rough. And if you don't meet the grade, which means hit a certain percentage of things being correct, it continues and it could get worse. All right. So very important, very, very important. All right. So continue the background, best practices of this system, of this internal auditing. How do you do it? All right. Clinical data should coordinate. So things should be representative of each other, right? The daily skilled nursing, rehabilitative services, and the MDS, all these things should be painting the same picture. I am telling you, man, I will go through therapy, evaluations, notes, research. Then I'll go through the MDS, and I'm like, this doesn't even seem like the same person to me. I don't know why. I'm not sure what the issue is, but one looks entirely different. It could be a completely different person. Reading the nursing notes. We all document differently, and that's good. That's fine. I mean, we should be. We should not be matching each other exactly in how we do things. There's no reason for that. But we definitely should be coordinated enough to make it under completely clear that this is the same issues, same person, same issues are being addressed, same issues are being worked on, that our focus is pinpointed to certain items of that patient's needs and making sure they're being addressed by everybody in the facility. That really is where you want to start with all this. Does your MDS, does your nursing notes, and do your therapy notes, do they all paint the same picture? Does this look like the same patient besides the name, the facility, and their Medicare number? Are they the same person? Do they seem like the same person clinically? Okay? And you'll be surprised at the stuff you think, oh, of course. Well, okay, well, I got some really good examples for you if you want to hear them where this is not the case. All right? Now, the financial information, what stuff are we looking at here? The UB04 claim data. That's that form that gets sent, the universal form that everybody kind of uses for either consolidated billing or the Med-B billing that you're going to be submitting your information on. Now, a lot of this stuff, sometimes people don't use the UB04 because it is clinically, they want to make sure everything's sound. But I tell you what, some of those items, if they're not filled out on the UB04 correctly, diagnoses is one example of a very good one. Admission dates, all right? If those things are incorrect, your whole claim could be shot. So I think it is worth looking at your UB04 data and making sure that it matches the background or the demographic data for all of your patients on all of your individual disciplines. You have a therapy. We're all writing this stuff over again, right? We're writing the name, the dates, the middle initial, the Medicare number, the admission date, the discharge, all those. They all got to match. That's where you start. Make sure your demographics are in line. What did I say earlier? We got to make sure it looks like the same person. If we have different admit dates, it definitely doesn't look like the same person because that person didn't come on the same day. Okay, so make sure you have all those things in order. It's a great way to start before you even get into the clinical stuff. All that other stuff comes along with it. The admission date, the occurrence date, the billing dates, all those things have to jive. All right, service dates, assessment reference dates, admissions and discharges, we already said. Leave of absence and hospital stay dates, all got to be in the jive. Again, it needs to clearly be the same person. All right, and if you don't even start with the right dates, you're already starting off pretty rough. Okay. Support documentation identified early in triple check. So what are the main things that we want to jump on that's going to support our claims? All right. Rehab treatment days and minutes of service if they're on therapy. PDPM or not, your rehab is over half of what your patients are receiving for reimbursement. Okay. Just because we don't have to monitor the minutes or get 720 minutes, 500, whatever it may be, it's still important to Medicare. And guess what? It's even more important to your residents. They don't care how you get paid. They really don't. They could give a crap. I almost said a different word, but they could really give a care. If you're trying to explain to them, oh, by the way, Mrs. Smith, we no longer have rugs. Now we get paid this other way. So you might not be getting as much therapy. You might be getting less, or we don't have to see it every day now, or we probably don't see it. They don't care about any of that. They care about getting better. And what you're delivering should be getting them better, okay? You get paid for what you're doing, right? Because it gets them better. But you don't decide what you're going to do, what you're getting paid, okay? That's backwards, all right? If you do right treatment, you will get what you deserve. If you can also follow the process and make sure that your claims, are painting the same picture, like I said earlier, that those are liabilities. All right. Respiratory therapy. Remember, respiratory therapy is another one of those disciplines, just like PTOT and speech, they have their own stuff too. So if you did do that, you got to make sure that all their stuff is jiving as well. Medical diagnosis, obviously, the documentation and the support, and then it meets all those guidelines in the REI manual for supporting it, that it's been addressed in the last 60 days, that it has affected the patient, or they're being treated for it in the last 7 days. Those two things definitely have to be in place. Okay, you can't pick diagnoses from 10 years ago that have been resolved, even though it pays you more. Again, you're leading in the right direction, or you're going in the wrong direction. You have to pick the one that you're treating, the thing that's actively setting your patients back, the main issue. That is what you need to be treating. You can't be digging through charts. Now, NTAs, they're a different story, but if you look at a lot of the NTAs, those things are long-lasting items that people are going to be living with forever. So, those are things that you should be actually still dealing with. But your primaries, your treatment diagnoses, you got to make sure that those are relevant and that they match. And if therapy is treating one thing, it should be the same thing nursing is saying they're there for. And that's what we're saying about these things have to really coincide with each other. They have to make sense. We have to paint the same picture. All right? Clinical service documentation and support for rationale. Why are we doing stuff with them? I hear stuff about hospitals all the time and the DRGs and, if you're eligible for it, we got to do it. I don't know about that. We do what they need. Is the clinical service you're doing documented? Does it support? Does it make sense? Are those treatments even appropriate for the condition under your medical diagnoses? Okay, you got to think about that constantly. You can't just code it, leave it up to someone else. I don't do coding, whatever. This is what triple check's for. Everyone's got to be clear on the same thing they're doing. Everyone's got to be clear on the same items that are being focused on their whole stay. That's what gets your bill. It's a consolidated billing, right? Everything's in there anyway. It's all together. Reasonableness and necessary, clearly noted and supported. So is this reasonable and is this necessary? Medically, is it something, is the treatment we're doing really going to make somebody better, or are we just wasting our time? Are the treatments we're doing in best interest of the patient, or are we just going through the motions of what we usually do with everybody that comes in here? They say those cookie cutter plans. You got to be very individualized. It's got to be reasonable for the person you're doing with, and it's got to be clearly necessary. Do they really need this? That's the key. And is it skilled? And is this a service that it even should be skilled for this resident? Do they need this? Why do they need it? And how is it going to make them better? All right, you got to remember the RAI manual instructions for PDPM capture. Make sure all those are met. Make sure things are done in their simple things like, was it even done in the window? Oh, let me see. Oh, that's right. I did the interview on the night. I couldn't get in there. Or speech therapist or even social worker couldn't make it in until the 9th day, and our ARD was the 8th. Well, guess what? That doesn't count. Okay, you have to do it in the window. Okay, you have to make sure. Sometimes MDS coordinators, they are very overwhelmed when you get tons of admissions on the weekend. So they start setting their ARDs. And now that therapy days don't dictate, many of our patients aren't always day 8 now. So they coordinate it maybe to their schedule or to how many they have to do on a certain day. It may not be unrealistic to know that there's an ARD on the 4th day they're there. All right. That means everyone's got to get their stuff done by then. Your window ends when you pick that ARD and it goes back. You got to make sure those things are within those dates. Very, very important. And finding out too late is not going to work. Now, are there things you can do to even fix that? Maybe not. But what did that say earlier? And the reason we're doing this, you have to have internal mechanisms to figure out your downfalls and your operations that are making your claims not accurate. It's your responsibility to figure this out and get it fixed. Okay? Because you don't want. Are you going to get paid for that one that you found? No, you're not, because you still can't. You're in this triple check and you're past that window. It's not like you can change it and go back in time and redo it. No, but you don't want that happening to the next 10 people either. Okay? You want to fix it, move on, and get a new process in place, and that's exactly what this process is for. Everything you see in here may not be fixable, but it's for future claims, and you're identifying your own issues and making sure you put something in place to get them right. Regulatory requirements adhere and are adhered to and noted. All the, I'm not even going to start going over all the regulatory issues we have to deal with, but making sure that you're meeting all the regulations as far as for therapy, a good example would be, the 10 visits for the Med Bs, the 10 visits, making sure that your evaluations are getting done timely, making sure that you have the appropriate supervision for your assistants, making sure that, you're communicating to the facility transfer status and that people are following that, or a weight bearing status. And that's all those regulations, man, making sure you have orders for everything that you're doing, making sure you haven't getting them signed and back in time, the 14 days for the verbal and the 30 days for the signing off on the certification. All those things, I could go over there's books of thousands of pages about these regulations. But the good thing, we're going to go through each one. That's the most important. So I'll help narrow that down later. But just adhering to those regulation requirements, even the basic ones, man. I'm telling you, sometimes I'll go to do a review. Where's your cert from the doctor? There's no certification. My God, that's like the first thing you should have. Sometimes you got to, that's why I put getting back to the basics at the beginning. Back to the basics sometimes. Sometimes the things that people miss are the simplest things that they're like, oh my gosh, I didn't even notice that. All right. It's a good time to sit back, especially a claim that's already kind of, you're out of the heat of it. It's already done, and take picture of it, from a distance and say, okay, what do I see here? What's right? What's wrong? And what do I got to fix? Identify, be your external auditors identify. See, that's what I was just talking about. Finding it yourself, having your own process to get your processes working right. All right. How triple check claim assure accuracy? How does this audit claim? How does this ensure this accuracy? How does this help really? Okay. Pre-bill claims. You want to make sure you catch some of this stuff. A lot of people, I wouldn't say a lot, most people want to do pre-bill. They have the process in place where they're going to review these claims before you send them out. I can say with COVID, that has probably fallen short at a lot of buildings because of staffing, because of other issues, because people working in different capacities. But that is the best way to do it. You want to be accurate. You want to get these before they go. You want to get these before they're going to get shot back at you, or before they're actually become corrections. Okay. That ensures accuracy. Then it doesn't get to the point where it's billed and wrong. It doesn't get to the point you have to do a correction, and it doesn't get to the point where it gets denied because you caught it before. All right. And every one that you could have caught before becomes that big denial is helpful. So make sure that you really try to do these pre-bill process. Now, is it better, or is it still worth doing afterwards just to say, okay, I mean, these already been sent, but we're going to do it quarterly. It's all we can really do. Let's just make sure all our stuff is looking good and see if there's any corrections we have to do and what we can do to make sure our things are better in the future. Yeah, that's worth it. That's still worth it. I wouldn't totally disregard that, but I'll make an effort to do pre-bill. You don't want a lot of things lingering out there that are liabilities. You just don't. Medicare Part A claims and other payers designated by the facility. You can ensure your accuracy across multiple payers as well. You don't necessarily have to stick to your Part A. So say you have an HMO company that's a real pain, and they have very, very weird rules that are outside of the regulations that, by the way, not everyone may know about. Your therapy program manager may not realize that this HMO company in their contract says you can't treat them on the weekends. I don't know if that's really true or not. I'm just trying to make an example. But it may say that. And then you go through your claim, wait, you guys are doing it every Saturday. We don't even get paid for that. Oh, we didn't know that. See, when else you can talk about this? Probably never. And make sure that you get your actual contracts, maybe write out the basics or have some kind of form of a way to verify and validate everything their HMO companies are pushing or requiring. Some may want a note every couple days. That's not unrealistic. I want a note on all your skilled patients and then you look and you're like, hey, you guys didn't send those notes. Oh, they're not going to even pay for this. So it's a great way to ensure accuracy among all your claims. You can pick Part A claims, which most people, start with that, especially with PDPM, getting to know exactly the Medicare stuff. I mean, you really got to get the Medicare stuff down and know all those regulations before you can even decide what's you have to do differently for the HMOs. If you don't even know what the regular way is for Medicare, how you even know what's different? You don't want to confuse the two. So I can see how that Med A's usually become the priority, but mix those other payer sources. Hey, I know some buildings, they have more skilled HMOs, more Medicare replacements than Medicare now. That's not that uncommon. All right. So, this isn't like something that's way out there. Some places have all HMOs now. So you have to have each one of those itemized to determine what does each of these HMOs need from us in order for our claims to be accurate. And that's the best time to do it. Everybody together, you all get to talk, get to ask questions, you talk to nursing, you talk to best way to do it. IDT representatives, you got to make sure everyone's there. And this is exactly what we're talking about. You have all the other interdisciplinary team, by the way, is what that stands for in case somebody doesn't know that. But you have to have everybody else in there with you so you can bounce these things off each other. You're all focused on the same thing. How many times we go to meetings, so-and-so's not here today. So-and-so, oh, they're busy, something happened. So-and-so can't come. It happens all the time, man. It's hard to nail people down. Dedicate this time, nail it down for this process, make sure everybody's there or someone else that represents that department is there. They can ask you your questions. A lot of questions go unanswered for weeks because we just can't get everybody together, especially in today's day and age and how crazy things have been with COVID. You got to make sure you just carve that time out. You guys can get together and just knock this out and make sure it's right. Routine review, and this has to be routine. This isn't something you can do every 8 months when you remember to do it, or when everyone's in that week or no one's on vacation. You should have a process in place. If someone's out, someone else fills their place, or a process in place to get that information back to them, and someone covers it while they're in that triple check process. This should be routine. This should be just like any procedural thing that has to be done. You got to get in a routine. You got to get used to it. It's got to be on your schedule, and people got to show up. That's the other thing that happens. I go there to help out. Three of the 7 people that were going to come couldn't make it, didn't show up. And that's probably more for administration to make sure that people understand where our priorities lie and how we need to ensure that things get done. Okay. Now, why is that all important? I mean, I think we kind of know why, right? We've gotten there, kind of covered that, but hey, want to do it, make sure, like I said, dedicate certain stuff to it. This is what you got to do. You got to dedicate the time. Why is it important? All right. Promotes compliance for sure. You want to be compliant. More people hear hey, I'm telling you, man, I've worked for a contract therapy company 20 years. I'm still learning stuff. I'm like, whoa, I didn't even know that. When you get together, you talk about compliance issues in multiple departments. You talk about experienced people who've been there for a long time, came from other regions, came from other facilities, maybe even possibly, and they bring over all their good habits and good ideas about compliance. You learn. It's a learning experience, okay? So it promotes compliance and people can interact with each other and make sure we're all on the same page. CMS guidance and regulations. If someone's in there who knows a little bit more, you can say, hey, I'm not sure about that. Let's check on it. And does somebody want you to check and see if these regulations, if we're meeting this regulation that we were concerned about. Perfect time to go over that. Perfect time to talk about resources to look at that. Perfect time for everyone to be on the same page. Hey, some people have different thoughts about some of these regulations. They say they're gray areas. They're a little bit different in everyone's mind. It's a great time to come together and decide, what is the right way, payment accuracy initiatives. So, you really want to make sure that accuracy, okay, is there on every claim all the time, preferably pre-bill, but you're taking accountability for yourselves in the accuracy of your claims. You're not waiting for a denial to happen. You're not waiting for a third-party auditor to be ordered to come in your facility and go through all of your things. You are doing this, initiating it yourself, doing it yourself, responsible for it for yourself, and you are making sure your payments are accurate. And you can prove that to your MAC or to CMS. It just gets you more respect, for being a provider. You want to take that initiative on yourself to make sure things are accurate, not just because you have to, because it's the right way to do it. Okay. That's what this proves. You're taking responsibility to make sure you're doing it right. And if it's wrong, we will figure it out and we're going to fix it for ourselves, not just because somebody came in here and said you're going to be in trouble if you don't do this. We want to do it right. Reduce denied, rejected, or adjusted claims. Okay. The more you do this, the less problems you're going to see. More people are going to know. The more they're going to understand. The more you get in this routine, the more things you're going to watch. Hey, I didn't even know that was happening. I didn't know, we were billing all those CPT codes for PT and OT and not putting in the right modifiers. I didn't know that, So now that you're more aware of it, you make sure it happens. You're not going to be knocking things off of these off your list of items that are going to be issues. You reduce your potential for medical review. Obviously, if you have nothing to get fixed, no one's going to come in here bugging you about it, right? So that's a great thing to always have that feeling. Prevent submissions of false claims. No one wants to, even a mistake. I mean, I always said, even when it comes to your kids, I know you didn't mean to do it. I'm not saying you but it happened. Okay, you got to figure out a way for accidents to stop happening. Even though I don't think anyone intends to do anything wrong. Well, maybe some people do, but most people don't intend to do anything wrong. I don't go out there intentionally wanting to get into an accident, but accidents will happen. All right. So anything you can do to further prevent those things from happening. Hey, I'm not saying you could be doing triple check perfectly and something may go through incorrectly someday. That could happen, but there's going to be less, guaranteed. That's for sure. I'm not saying you'll prevent every one of them in the future, but I guarantee if you do this regularly, you'll have less. Appropriate report for facility data. I mean, hey, quality measures coming right off our claims, right? There's claim measures. All this data that we're putting on these MDS is what we're using clinically, even the covariance, the depressions, all the things that are going on here about your patients clinically. They're using that data to project quality measures for your facility and even your 5-star, feeds into that even, so your projection, and I've said this even when I'm doing my MDS training, accuracy is the key. The more appropriate reporting you do for your building, the more accurate it is, the better your facility is going to look. Or, hey, and if any great time to figure out, you guys, we're really dropping the ball in these areas clinically. Our stuff may look right, and we reported it right. It's looking a little bit worse than I thought, and that's why I wanted to double check it. But it is right. We need to work on this better. See, it identifies problems in your facility that really don't even have to do with your claims. Okay, it really brings to light what you're doing collectively, monthly, or whenever you're doing this process. So it's a great way to just check the overall operations of how your facility is going. And then obviously accurate billing for services provided. We always want that. We want to be accurate. We want to make sure that our residents' resources are used the right way and that they end up benefiting them. And then we're being efficient with what they have. Remember, all the money we're talking about is the residents' money reserved for their care. And when we're talking about claims and dollars billed, remember where that's coming from. Very important that we keep that in the back of our head. It's not like it's our money, or it's not like people are coming in here willfully paying for a dinner or something. This is for their care, and if it's not managed correctly, they suffer. So these things have to be right. And the more accurate, the better for everybody. All right, that was it. That's the first section. So we're going to move on to the second section here, okay? And we're going to actually move into the process. How should you do this? I mean, what do we do then? All right, John. Okay, you got me. Yeah, we probably have some things going on I want to know about. Well, how do we have to do this? Okay. First of all, who should be part of this? Who should be part of your team here? Okay, your team should include your business office manager or some office representative, your rehab. And these are the minimums. There's other people in here we'll go over later, but these are the main pieces. The rehab therapy representative. I know sometimes contract therapy people don't want to involve this because it affects productivity, but their manager should be attending this, especially under PDPM. It's even more critical. People thought it was more critical the rugs. Well, not really. I mean, really anybody could count the number of days and number of minutes, add it up with a calculator or something. I mean, that really doesn't seem too tough. But when you're talking about, now we're talking about clinical stuff, it's more clinical. So more than ever should be a good representative. Usually maybe a clinician, program manager would be best, or even a therapy. Have a backup person just in case, a therapist or OT going in there and representing this wouldn't be bad either. A nurse representative, RN's preferred. Again, want to look at people who have being a clinician and can make some of the other decisions on something was clinically appropriate or not. You got to be careful on who's making those decisions in some of these situations. So the RN usually is preferred, and they have a bigger understanding of the big picture because they oversee more of the medications anyway and some of the higher level clinical services. So it kind of makes sense because you got to cover all those things too. You may be with someone who, I got to check on that. I got to check. And that's the last thing you want is another level of checking. This meeting is this is the checking. This is the time. This is when we're checking it. We don't want a whole bunch of notes and a whole bunch of things going out to be rechecked. This is it. This is when we do this. And that needs to be kind of the standard. Okay. Additional team members. That would be helpful. Obviously, your DON, ADON, and rehab manager. And I was kind of getting into this earlier. I didn't want to go all the way into it. But if you want to make change, right? And if you see processes or operational items that are not working correctly or need to be revised, those are the people that need to make sure they get revised. And then letter A, the next person, B, administrative team, administrator, COO, it's even a higher level. And those people, that is their role to make sure these things get fixed. And I think it's a great idea to have one of those people in there making sure, oh, they're not clinical. I know they're not, but you know what? They're the ones that oversee the clinical, and they oversee the operational part of the clinical, right? You're not in there doing direct patient care. You're in there reviewing operations and how things are working. Why not have someone in there that can hold people accountable for this, or it's not going to get fixed? So it's important for those people to at least take part of this partially, maybe not go through every piece of it. And I know their time is very important, but at least for the end or the beginning, see what operations need the most help and making sure that those get fixed. And then your operational managers, MDS coordinator, obviously, especially now under PDPM, that's even more important. Social worker, the restorative nurse would be a good person to be in there as well. We talk about functional maintenance programs, and the functional maintenance idea, maintaining function. Even though skilled therapy is done, how are they doing out there? Skilled therapy saw them for 3 months. Hey, how are they doing with the nurses now? Oh, I don't see any difference. Well, that's weird. Did 3 months therapy, you would think they'd be a little different. So, it's funny, but it's not funny because that happens a lot. So you want to make sure that what we're doing is having the right effect, that our patients do seem better, that they are transferring better, they are moving better, that even seem like they gotten stronger. I don't know, something. But you need that whole continuum, great clinical oversight of your operations, and of course the billing oversight and making sure that the billing is billed appropriately. All right, business office items. I say you have the UBO format. I'm telling you, I would have it there. I would have a copy of it just to make sure that those things are checked off right. And I don't want to get into that too far because I go into that pretty deep in a minute here. So I don't want to waste a lot of time going over it twice. The bill type, you got to know if it's A, B, HMO, and what are the requirements for those bills. That business office may have those contracts, and may have the details in those contracts and how they're supposed to be paid. The omission and occurrence dates, which could be different. The omission date, the occurrence dates of the treatments being delivered, and the HIPS codes and everything, all those things have to be coordinated, have to be made sure they're being billed the right way. The delivery is one thing, and how they're on our treatment grids or how they're noted in the medical record. But how were they billed and what dates were they billed, and the occurrence dates and some of these other reference dates that are in there, are they in line with how they should be billed? Or are we going to be out of compliance with something and maybe have some kind of billing error come back? Modifiers, things like that. You got to make sure all those things are in a row. Hey, remember back to the basics? Make sure you have the correct payer, number one, and make sure all the disciplines and all the IDT team have the correct payer. I've seen claims go out and therapy had the entire wrong payer on the whole time. Okay. Is that painting the same picture? Of course, no. It looks like you're their HMO, their Part B. You put the Part A claim. What's going on? How do you not even know what the payer is? Make sure all these things coincide. Seems like an easy mistake. Maybe it is. But if it happens too much, it's not a mistake anymore. It's an issue. It's an operational issue that you have. Make sure we have the correct payers. Make sure your IDT team knows that if this is an issue, why don't you have the correct payer therapy? Well, they never tell us, or they tell us too late. Okay, business office manager, 1 week after our therapy is started, you go to that therapy, you make sure they got that right payer. We should have it. Maybe you might not have it for day one. Maybe there is some confusion. I don't know, but you definitely should have it by day 7. Somebody needs to follow up, make sure everyone has the right stuff, make sure they're getting that timely, and over time, that even should be getting better and more efficient. But if you don't have anywhere to start, if you don't know it's a problem, you're not working on it. That's for sure. There's lots of other problems we're working on. We're not making them up. We're not making up new ones for no reason. This would identify that problem and make sure you get it fixed. It seems like a really basic one. One of the biggest problems we're seeing. People don't know the correct pairs. Resident data, name, social security number, all those. Do they have their name right? Do they have their middle name right? Their middle initial? You'll be shocked of how many people have the same names out there. Even the names you feel would be unique, they're not as unique as you think. Some of them are very close. Even maybe not the exact name, but very close. So make sure all those are exactly right. They have, and that's an exact science, guys. Our numbers, our names, they should all be 100%. Not having those right is a problem. That is one thing that should be for sure. We should definitely have the demographic information 100% accurate. Facility information sometimes. Are we writing the right provider number? Are we writing, if there was done an outpatient, or maybe you have an outpatient clinic. Was it done an outpatient? Was it an inpatient? I don't know. Maybe was the room number correct? Did they move rooms? Was that noted? Did they have the new room numbers? Did they have any? All these things, again, painting the picture of consistency, and will lower any questions they have about the claim. So I want things to be accurate. All right. Items from the nurse. Okay. We're going through each one of those disciplines. MDS assessments and PDPM capture for nursing, obviously. And NTAs, some other stuff, Again, when it comes to MDS now, guys, it isn't chopped up rehab, nursing, social work. You all should be knowing these things. You all should understand how PDPM works, and you all should have the ability to check it. Hey, I've even seen this as a process they do in some buildings. They'll have different IDT members check different people's stuff. Like therapy may help check some of the social work stuff. Dietary may be helping check some of the nursing stuff. Now, they may not know it, clinically, but they were just looking through to make sure all the checks and balances are there. Hey, why doesn't this have an order? Shouldn't this have an order? Oh, yeah, it doesn't. Or they say, no, that doesn't need a doctor's order, like restorative therapy, restorative nursing program. That doesn't need a doctor's order. But, hey, it is. Should we do that? Is it best practice? Maybe it would be good if we had it. See, if you don't have these conversations and you don't go through these things, those questions don't come up. So sometimes you can cross disciplines for these things, but for the nurse, initially you would say MDS, PDPM items, even some of the PDPM items related to section GG. Hell, what's going on with that now? Who knows? It's therapy, nursing, whoever. Those cross lines all the time. So some of these things may ever leak over to the other disciplines. Physician ordered and care plans, definitely the physician's orders, care plans. Definitely with nursing. Physician certs and recertifications, talked about that early, you definitely need certs. ICD-10 diagnoses and NTAs, identifying those things that are going to be long-lasting with the residents. We're getting paid for those now, so really, really important. Validation, and really important clinically too, how to treat your patients. Skilled services provided, especially with some of these patients that were on the waiver for not having to go to the hospital for the 3-day stay. You still need a skilled service, and it better be clearly documented, or that claim's not going to be paid. Section GG documentation. Make sure it's clear how it was determined, or have an RN note to support. I actually put that in there a little bit additionally because we're seeing a lot of section GG, all right? And it's kind of all over the place. You got these 3 days being documented with your nursing staff. They may be min mod, or like partial, moderate assist, max assist. I was talking therapy language. And then on the therapy notes, it has the min mod, mod max stuff. But when it's chosen, rightfully so, with the RN and the MDS coordinator, they get together. Maybe the RN is an MDS coordinator. She's doing it herself. And she's saying, hey, I'm looking at this stuff. I'm going to make this clinical determination. They're going to be right here. And then there's really nothing to support that exact right here. And you really don't know why you got that, or there's many other things that showed up once too. How did you come to that? Sometimes a little quick note from the RN, pick this one because they were very dizzy the first day they were here. Next 2 days progressively got better. Now their usual performance is at partial mod assist. First day they were max because of this dizziness. Now they're better, right? It's a little something to justify that. So there's just something to validate why you picked that one thing. Even though it was scattered and nothing really is consistent, why would you pick that one? Okay? Just want to make sure that it's based on clinical decisions and that was, at the time, the best decision you could make. Was it right? I'm not necessarily saying right or wrong about anything. I'm just saying, why did you choose that? Okay? And then the rest will be determined on how you document on the movement forward. Maybe they got worse or they got better even than what we thought. That's fine. That happens. But why did you pick that final GG score? Make sure you write a little note on that. If there's no clear indication, if all 3 of those days weren't the same, where did you pick it? Did you guess? Did you just close your eyes and point at one? That was the one you picked? No. There's got to be some reason why you did it. Okay? All right. Now, rehab and therapy. Obviously, therapy treatments and service logs. Hey, guess what? 5 days a week is still required, guys. Don't forget, just because we're not using it for payment, you still should be delivering 5 days a week of therapy for skilled patients especially if they're only skilled for rehab, because you could lose the skill that way. Now, remember, a lot of these nursing issues may be resolved, and all of a sudden therapy would be the only carrying skilled service daily, but for us, it's 5 days a week. Everyone knows that. But sometimes when the communication stops, right? We only got this one assessment. What do we have under rugs? 5 day, 14, 30, 60, 90. Now we have the initial or 5 day. That's it. Boom, done. People don't talk about them as much anymore. You don't talk about these claims for an extended period of week after week after week because there's no more assessment reference dates. And people may not be discussing it enough, and they shouldn't be doing this, but hey, it could happen. Therapy may decide, well, I'm only going to see Mr. Smith 3 days a week on a go forward. And then people are thinking, well, it really doesn't matter anymore. They're locked into what they are. But still, they're not skilled anymore at 3 days a week, right? So you need to make sure that your therapy jives, and that if they're the only skilled service they were in there at the time, that they were still doing it 5 days a week. And hey, this is a slippery slope, I guess. For holidays, we really pushed back in the day. We got to do 5 days. We're going to have to do a COT. We got to do 5 days. We got to come in day after Christmas. People aren't doing that anymore. I've seen it. I'm sorry, you're not. You should be. If that's what really gets the patient better, we should not be changing those processes at all. We should be trying to deliver every day that they're supposed to be getting, just like we did under rugs. Why did it change? Because you're not going to get paid, or you could get paid less. That can't be a reason, guys. Sorry. We can't make our clinical decisions based upon our payments anymore. Your rehab team should be delivering 5 days of therapy to everybody every week, just like they were under rugs. That shouldn't have changed at all, and it has. And people who are telling me it isn't, great for you, but I know it has because I've seen it in most places. It's not a priority because you don't have that threat of the COT anymore. You don't have that threat of not capturing 5 days for that assessment anymore. It's not there. But clinically, regulatory-wise, we still should be delivering that same level. All right? So keep an eye on that. You can't. With rugs, it was easy. You see your rugs drop, or you see, somebody that was getting 500 minutes, all of a sudden now they're getting 300 minutes. What happened? You don't see that under PDPM. They may be delivering 200 minutes when they used to deliver 500. You're not going to know. You need to make a conscious effort to make sure you do know, to make sure your patients are getting the clinical care they deserve. All right. Plan of cares. Plans of care, physician orders for rehabilitation services, to make sure that certification on that plan of care signed by those doctors, that it matches the delivery of services that were delivered to the residents, right? You got to make sure that is going to be still monitored, even though we're not counting those minutes and days anymore. Rehabilitation support documentation for reasonable and necessary. Are their services reasonable? Are they necessary clinically, medically, whatever you want to call it? But what it really means at the end of the day, did they really need it? And do we really need a skilled therapist to do it? Because regardless of the minutes not making the rug for the reimbursement anymore, Medicare is still paying us a lot of money for these people to get therapy. They say 90, but I think it's probably more about 95% of the patients that go to SNFs are there for some kind of rehab, right? So make sure what they're getting is appropriate and it's necessary, that it's not just lifting a cane up and down, that it's not just using a pegboard, a shoulder arc. What are they doing? Is it in the notes? Is it clear that this is a skillable delivery of services that Medicare should be paying for? If you don't see that and what you're looking at, I see a whole bunch of stuff, people writing, therapists writing about what patients do and not writing enough about what they're doing. I mean, sometimes I look at it and it's all they're writing. Patient did this. The patient lifted a cane 10 times, 2-pound weight. Patient transferred from chair. And I'm like, well, were you even there? Were you just watching, or someone else tell you about it? There's nothing in here about you as a therapist. What were you doing? And we're going to be doing a documentation review or webinar just covering that stuff. That's going to be pretty helpful to people on how to do that. There's put together a pretty cool way of reminding ourselves on how to do this, because that's a major problem, man. I'm telling you. That's why claims don't get validated. I'm never going to say it's because a therapist isn't trying to get somebody better. They're not documenting what they're doing and why a therapist needed to do it. And I'm not even saying what they were doing wasn't good for the patients. It was, I'm sure. But you got to really, really document why you, as a therapist, your skill in that process. And lots of therapists are not good at that. I'm going to be really honest. They're not. I probably wasn't good at it when I, first got out of school. It's something I've learned, and it's something I learned through talking about regulatory issues, or actually looking at the Medicare benefit manual that no one else really looks at, especially therapists, especially contract therapy companies. I don't even know if they know what it is. Well, they probably do, but they don't cover it enough. I'll tell you that. All right, so section GG, supportive documentation, making sure it's clear. We talked about that earlier. Does therapy have to absolutely match nursing? No, it shouldn't. I'm telling you, this is a touchy subject for me. Okay, how they changed certain therapy documentation to match the MDS's levels of function. That's ridiculous. We didn't even learn that in school. Okay, we learned mid, standby, contact, mid, min, mod, max. That's what we learned. Okay, we didn't learn partial mod or supervision to contact, but that's what they're using. There's a way, guys. I figured out. You really, am I the smartest person in the world or something? I mean, no one else can figure out how to make these two things jive together. Therapy uses a different language. So what? It's still relevant, and it's still leading to the type of assistance a patient needs. You just have to understand it. Take a little time to figure it out. Take a little time to go over it. Talk to your therapist. Watch my GG webinar. You probably have a pretty good handle on it by the time you're done with that. That's all you got to do. You don't have to change your entire company's documentation so no one can make a mistake. Mistakes happen, but they happen because they're not trained properly. Not because the levels of function are incorrect that everyone's learned in school ever since the beginning of OT PT school. I mean, they haven't changed at all. It's crazy. It's crazy that they even try that. And you know what it does? It lowers your skills, or lowers I don't say it lowers your skills, but it lowers your perception of skills. Okay? I think it makes those therapists, look more unskilled. I mean, I don't know. It's a bad idea. It's a really bad idea. So they don't have to match exactly. They just have to be similar. Sometimes we as therapists, we're really challenging a patient to do something. Okay, so if I'm challenging him to do it in a different way that's purposefully challenging to them, that I know they can't do it by themselves, or they wouldn't be in therapy practicing it with me. They could already do it. So I can assume they're not going to be able to do certain things. Okay, we have a different agenda. Nursing is there to help maintain the patient's functional ability and giving them the assistance that they need. Therapists are there to challenge the patient and take them to another level. So some of this stuff isn't going to be lined up. We're not doing the same stuff. Okay. And that's okay. That's the way it should be, really. Because that's why it makes us therapy. It makes them the nursing staff. We have different roles. That's all right. But they got to paint the same picture. All right. Okay. Other items that can be evaluated. Secondary payer information. All right. Sometimes you have a secondary insurance that has certain requirements, okay? Making sure that those are brought to light and everyone understands them. Assessment interview results and accuracy. Now we're talking about payment again. The BIMS, the PHQ-9, even the pain assessment. Although it's not linked directly to payment, it's still very important. You will get nailed on pain in your building. I'm telling you right now. You don't think that's important? Don't worry about your pain assessments or follow up on pain issues. You will get hammered in a state survey over that. Okay, it's still very important, even though it doesn't pay you on the individual MDS. It will be a real big liability if you don't have a good handle on it. We don't want our residents in pain, and if they are in pain, we got to be handling it. Okay, MDS ARDs, the assessment reference date and the transmission dates off the jive. If I have a different reference date, I start counting back at a different time to add up my minutes for the MDS. If social work has a different assessment reference date for their interview, they may fall outside of that window. Section GG, it's not clear where the assessment date is. They may be counting these 3 days, wrong, especially for those facilities or those states, I should say, that have the other state assessment, right? So when you do that for your Medicaid reimbursement, you have to know where that ARD is so you can start your count for your section GG. You don't know exactly where it is. Where are you counting from? You don't know. Is it wrong? Is it outside of the window? You're not going to find out until you triple check. And then you're going to say, well, we need a better process in place where everyone knows our ARDs. Okay. Got to make sure that those things are covered. The NOMNAC, and then your ABN letters and all that stuff, different payer sources, but make sure that all things, those are going out timely. The census data, the eligibility verification, that's that, what do they call it? The system, the Medicare system that tells you what days people have left. Make sure that stuff is all accurate. Make sure someone's checking that. It's not assumed 100 days. What if they went to another building and they used up 30 of those days? It could happen. It happens all the time, actually, more than people think. All right. Make sure you know what people have left. Make sure somebody who checks that verification is communicating that to everybody. The reconciliation with external vendors, billings, laboratories, radiology, pharmacy, even therapy. I got to tell you, I'm going to be really honest with you right now. I would say 50%, if not a little bit more, probably more around 60, 75% of invoices I check for therapy have a few errors in them. I'm not talking about a ton, but I always find errors, always. Either days, hips, because things change sometimes. The discharge date was communicated wrong. I mean, legitimately, it wasn't an error really. It was just they were given the wrong date. That midnight idea when, so-and-so left yesterday. Well, really, they didn't leave yesterday. They left today because it was 1 a.m. That alone, that's already an error. Admission date, hospital admission date. Sometimes those are wrong. So make sure your bills are right. Okay. Make sure that, it's worth the time to check vendor bills. And some of them are confusing. We help out facilities with therapy bills. So if anyone needs some of that, you can let us know. We can analyze that and make sure they're accurate. We're talking about MPPR reductions. Now we're talking about the assistant reductions. Are all those things right on yours? It's hard to see it. If you really don't know how to break it down, it'll be hard to find. Okay. Items to evaluate on the UB04. Again, not everybody uses these, but I think they should. Name, date of birth, Medicare number, Social Security number, all really important. Bill type. What kind of bill is this? Is it consolidated billing bill? Is it, is it a HMO bill? It shouldn't have been sent. Is it a Med B? Is it an outpatient? What is it? And I tell you, when you see the FL04, that is the locator number. What do they call that? It's where it is on that bill, that number. Every one of those are numbered. And I have an example of it in my resources at the end of a UB04. They all have their own a locator number where it can tell you where that actually is. So the admission date is going to be the item box 12. So where you put all these dates. I have a really good key for that for you guys to use as a resource at the end of for download at the end of the presentation. So you can always use that. So you know where these items are, because when you look at a UB4, man, it's busy. There's a lot of stuff on there. The occurrence span, qualifying hospital stays, when were those? So all those things have to be looked at. The correct payer source, again, form and the dates of the claim, the billing period claim dates. What days exactly were you billing? What days did they stop? Were they accurate? Was it the same days that therapy stopped? Was it the same days that the nursing skill stopped? Do they match your UB04? All these dates have to jive, man. And it can be overwhelming at times. But that's why you have to have this process down. You have to have a process for it. And you have to have people who know how to do this and have been take part of it routinely. Because I tell you, when you first start doing this, or you start doing this with a new team, it takes forever. You're like, oh my gosh, this is ridiculous. But I tell you what, if you get in that routine, if you get it down, you get better at it, and it becomes a pretty smooth process. And guess what? There's less things you're finding. That's one of the reasons. Field locator, boom, just hit me in the head. FL, that's field locator. Revenue codes, they're very important. Is it PT? Is it OT? You got to have all these codes, modifier codes, all these things, very, very important. They're all on these UB04s, and if they're not on there correctly, it's not going through. And by the way, if you do send it out and it gets kicked back right away, it's probably something entered wrong. That's not like a denial or Medicare saying we're not paying for this. Just to get it, there's certain required criteria to get you in through the system, to pass the system screening process to even make it a legitimate claim. And a few things wrong here or there can kick it back. Just resetting those, man. Just get them squared up, see what you got wrong. And if you have a good triple check process, you'll know right away what you got wrong. Send them back in and rebill them. Don't think that's something that you can't rebill. All right, triple check process, the internal audit. So when we look at these documents, the results of the findings, so we want to make sure that you have a process that you actually can record the things that you got wrong and get new things in place to get them right. You want to document all these findings that, and it's not necessarily something that's going to get you in trouble. Oh, we don't want to write down we were doing that wrong. Well, you kind of do, because you're kind of trying to fix stuff. And that's the great thing about an internal audit. Who isn't trying to better themselves would even audit themselves and think that's going to hurt themselves. I mean, why people want to know that you're doing this? It's important. Yes, you're required to do it, quite honestly. So make sure you document everything you've gotten wrong and make it part of your quality assurance performance improvement process. Your QAPI. There you go. That is a perfect thing that should be in there. These are the things we're finding. This is what we're doing to get it fixed. And this is the results to show that it's done, right? This should be part of your facility's process to monitor yourselves. It's not wrong to put something that you did wrong. And I tell this to everybody when we're talking about state survey or claims, they're not looking for people who make honest mistakes. They're looking for people who purposely do things to either cover something up they did wrong or increase their profits. They're not looking for people who just made mistakes. Now, if you continue to make mistakes, if you don't have a process in place to get them fixed, now you're someone that's just trying to cover up something they're doing wrong, or someone who gives the perception that they don't care that they're doing something wrong. So that's why you have to make sure you're taking note of all these findings and putting them in a performance improvement plan, which is going to be your QAPI process. Consider external audit process to validate things like what we do. Have that third-party auditor to come in and say, hey, John, we've been working on our triple check. We think we're doing a pretty good job. We really found some good stuff. I think we really got it fixed. Would you mind coming in, maybe doing a quick an audit of the last quarter and see what you find and see if our findings are accurate? Hey, it's worth it, man. I'm telling you, you get in a routine, sometimes you routinely screw something up. Sorry, I'm just saying it. Or sometimes you routinely miss something. Again, honest mistake, not something you purposely did, but there may be a piece of your process that's missing something, a very critical part that continuing to get through, you don't even notice it. And since you haven't really gotten any ADRs, or we've gone a while without a big onslaught of ADRs or denials because of COVID and everything else, you don't want that. Okay, so if you didn't see it, it's fine for someone else to see it for you. All right. Okay, so that was section 2. All right. Now we'll move on to our third section, which will be the last section of our objectives, and that is the claim review process. Okay, going through some of the items. And now I'm just going to say it right from the start. The better you know PDPM, the easier it is for you to know this. And the better your team collectively understand PDPM, the easier this process is going to be. The last thing you need is to go into this process, to check your claims, to verify all this. You're just getting all things put together, check all these dates, take all this time, and then you're trying to explain to people how PDPM works. That's why I'm saying everyone in your building should know how PDPM works across the board. I mean, they should. It will make it more accurate coding, and it will make your claims more, or have less liability, I guess. So, and then make this process a heck of a lot faster if you don't have to explain to everybody how PDPM works and kind of what you're even looking for. all right, or how to validate something. How do I even know if this is right or wrong? Or how do we, what contributes to, what are the requirements for a modified diet or a swallow disorder? What does that even mean? Do they have to have a diagnosis? Do they have to do it 5 days out of the 7? Is it just 1 day? If people don't know these things, you're going to be having a PDPM teaching session every time you go in here. It's going to take you twice as long. Okay, make sure your people understand PDPM. Go in here to review these claims. It's going to move 10 times faster. So what I did is kind of broke down some of the main items here and the source that they're going to get them from. I thought this was going to be a little bit helpful. So are all your demographics correct? It's on your UB04. That would include the Medicare billing ID number. Secondary insurance, has that been verified? Is that correct? Is it even on there? Did someone even check it? I don't know. This is the good time to find these things out. Date of admission, is that right? Is it right across the board? Eligible days, that's your verification system. Qualifying stay at the hospital, that's off your hospital documents, and it would still be on some of the other, therapy items, things like that. Are those all accurate? Is the MPI number correct? Is your CMS certification number correct? I don't know. Let's make sure. Hey, it should be. Well, should doesn't mean yes for sure. Okay, a lot of things should be okay, but they're not. So making sure that you have these basics down for the billing, really good place to start. All right, now moving on to the PDPM items that have more to do with the billing side. The Med-A certification, all right, is that initial certification signed and dated by the doctor, with that 72 hours of admission. The reason for skilled services noted in each time frame. Sometimes people come in, what are we skilling them for? That's the first question. No one even knows how to answer it. Well, usually they're going to get therapy. It falls on our shoulders every time. But with PDPM, it may not. You want to know, now it's every skillable service, okay? And that's why some of these nursing scores aren't up to par yet, because they're still relying on therapy skill. It's really easy. If they get in therapy, and that's basically it. What skills are we going to be delivering to this patient? And they're all documented. Are your recertification signed and dated by the physician on or before day 14? And then every 30 days after, are all those in place? Are all those dated correctly? Recertifications describe the reason for skilled services, the anticipated time in the SNF, or the post-care stuff. There's all that stuff in there. Beneficiary notices. Were the beneficiary notices issued? Number one, were they even there? And were they dated correctly? Did they go out when they were dated? Did somebody write them and leave them on their desk for 3 weeks before they went out? Or not send them out at all? Okay. If change in the level of care and remains in the building, was that notification told? Was that sent to the family members or to the patient? I know you're saying long-term care, but you're losing this benefit. You have to notify them of that. That's a regulation. If discharged for the facility in the days remaining, was it sent on that NOMNAC? Was that sent to the mailed out and received in appropriate time? And was a denial notice issued? And if appealed, did all those processes take place that those patients are entitled to? If we're saying they're done, did they go through were they offered even? And did they go through the process of that? And then there's some of the other building stuff that we already went over, but this is more of on all the other pieces of the claim. That first part I was just talking about, that was the UB04. Are all these things being correct? Because you've already checked the UB04 quickly, make sure that's correct. Does that match your therapy documentation? Does that match your, if you had a diagnostic company come in, a blood company come in and draw blood and get it tested, whatever vendor, whatever services was delivered, does all their stuff match? And is it all the same person? Is the gender correct? Is the bill type correct? Is the payer correct? There's all these different things that kind of have copies of the same information. They all need to match. We're painting a picture of the same patient here. You start messing up some of those things, really skews it right away. All right. Patient status code, correct. The verifying the 3-day qualifying inpatient stay correct. The admit date, readmit dates. Sometimes those are off. The dates and services correct. Was the therapy services, when we say they started therapy on a certain day, was that the day the eval was done? Okay, making sure all these things are matching. Does the HIPS on the MDS agree with the MDS information or the data that we have in the chart? Do all those, jive? Or how we're billing it? Is that the same? Sometimes those things you're dealing with a lot of numbers and letters, and sometimes you just screw up and write them the wrong way. Okay. Verify census days, room, board days, and any other days, especially outing days. If they did leave for a family, what do they call not necessarily hospital stay, but a leave of absence, just for a family for the holidays. Is all it in there? Does it all make sense? Co-insurance, bill days from DS correct. Admission diagnosis, talked about that earlier. The confirm primary diagnosis for skilled care. What's that give us? Clinical category. Is that the right one? Does everyone agree? Was it the one we were treating the whole time? Or did someone just pick that one because it paid the most? Or was that the actual? It's one of the things we check to validate claims for CIAs. Is the diagnosis you chose that made you or started your PDPM reimbursement cycle, I guess, or algorithm, was that one that you guys were really treating? Was that the one? Was that the right one? Okay. All those things have to be in there, and all those things are very, very important. Ancillary service listed, labs, radiology, medical supplies, pharmacy. Pharmacy's a big one. Was all the pharmacy stuff right? Was all that stuff in there, accounted for? It sounds like a lot, but again, once you get your process, you get it down. Now, when we get into the clinical side of it, Med-A, MDS, documentation, certifications, and the source, the clinical sources, matching. All right. Again, admission dates still have to be right, but they also have to match clinical dates. Make sure their clinical documentation has the same dates. Qualifying inpatient stay, Med-A, again, certification, accurate is what the doctor put on the cert, what we're doing. If they put PT, OT, and speech, were they receiving PT, OT, and speech, or were they just receiving PT and OT? No speech. Why? Why are we putting speech on there if they're not getting it? And what do we do to make sure that was both acknowledged and discharged the right way, if it had to be? Was the MDS open and the ARD set within allowable timeframes? Remember, you got to open it. You got to choose it during that window. You can't wait and see what happens. You got to choose it during that window. We all use computers now. The stuff can be figured out. Okay, was the IPA assessment? Nobody knows because nobody does them, right? That's a whole other in-service. But if you did do an IPA, was it accurate? Were the dates picked? And was it coded correctly? Okay. Sometimes with the IPAs, you forget about the skills that you lost or the skillable service maybe that's no longer being treated. You have a wound and the wound gets resolved, but you're doing an IPA because they're getting speech therapy now. I forgot that wound. They didn't have a wound anymore, but we kept it on there because we just ran through the MDS and filled in all the stuff because we thought we knew it all from the initial or the 5-day. Okay, did that happen? And if it did, you better fix it. Don't send it like that. It happens. Okay. Section C, the BIMS interview. Was it accurate? Does it paint the same picture? Are we looking at her claim and saying, there's a BIMS in here of a 3, okay, and then we have 15 on our MDS. What happened there? Well, how'd that happen? She was very, very confused, but we have this. It happens, man. Nobody knows why. I don't know. It's a mistake. Mistakes happen. That's what we're looking for. Again, I don't think these things are purposely done. They're mistakes. But if you see that happening, there may be a breakdown in the process. Maybe who's ever doing the BIMS isn't getting it to the right person and they're not getting it on there in time and they're assuming they're 15. I don't know. Or maybe they did it too late. Maybe they didn't, write it out the right way and get it to them the right time. You never know. Is it right? Is it accurate? Do they match? And if not, why not? And let's figure it out and let's get it fixed. Section GG, 1020, coded accurately for the MDS and the rehab documentation. 1800 is the some of the diagnoses issues that we'd be putting on the back of the MDS. Making sure that all of those are accurate and all those fit and all those are active and they're all things that we may be treating. All right. AIDS is one that pays very highly. Is that being coded correctly? And there's some special things for that. We won't get into that right now, but if that is being captured, is that on everything that needs to be on? With there's a few other items you have to do with that, but if that's there, all those items there, and you should know that if you're coding it. Are we looking at our HIPS codes? on the Z100A and the UBO4? Are those two things matching? Is everybody signing Z400, which is what, those signatures because they were involved? Are the therapy certifications and recertifications complete, accurate, signed by both the therapist and the physician? Are the medical record documents support medical necessity? This is the whole. Well, that's really not a fair question because that could be a whole 2 in-services right there. But again, is someone addressing that? Do we know our therapy claims are validated because we have a third-party auditor, we have a company that helps us with this, or the therapy company does it? How are we making sure? It's a good way to start. Hey, let's look at the therapy documents and just look at them real quick. Do they look like, or what is our process for that anyway? Because that in itself could be a long time to check. But hey, it's a good place to start talking about it. And if you don't have anybody, say you're in this program, you don't have some kind of consulting company checking them, you don't have the support of a contract therapy company checking them, it's a good time to say, hey, maybe we should get somebody to look at these because I'm really not sure, or we really can't take the time to go through all these and make sure. Maybe I should have somebody check them once in a while. Good time to talk about that. Resident's name, resident's plan of care, accurate and complete, LOA days, and any dates of service on the UBO4. All those things. I know it's a lot, but it's all important. Every one of them. ICD-10 codes, and then I-20B, clinical category. Touched on that already. Has the doctor certified that, and is it really what we're treating? Section GG, validate SLP case mix group. Why is that? Okay, because that's where that altered diet, swallow disorder, are both those things documented in the chart? And if so, are they clear? And is it easily, would an auditor come up with the same conclusion that we came up with by what we see? Okay. Any comorbidities supported by the documentation for speech that contributes to that? BIMS, cognitive impairment. If it wasn't completed, are they doing the assessment or the staff assessment one if they can't complete it themselves? And was that accurate? And does that accuracy support, whoever did that? Does it support the real depiction of the patient? Does it make sense? If she doesn't seem confused to you and she seems to be doing everything, and you had someone do a staff assessment, which would be weird because they're supposed to be able to let them do it on their own, and for some reason they said they couldn't do it, and all of a sudden they have a 1, you're like, wait a minute. Okay, maybe she did the wrong maybe they did the wrong person. It happens. We're talking about a lot. Some of these facilities, you guys have 20, 30 Medicare. You have 10, 15 admissions, 10, 15 discharges every month. This can be confusing. It's not unrealistic to think that you may do something with the wrong patient, put the wrong name on. Say you do 2 of them in a row, you get confused and you don't notice it. Hey, this is the way to find out. We talked about swallow disorder and altered diet already. Validate the case mix group for nursing. What clinical services are we delivering? What's the skilled clinical service, and what category does that put us in? And do we miss anything? Section GG, again, we already talked about. These are all the OT therapy requirements. I'm not going to go through all these. Basically, it's, evaluation to discharge. And there's everything else there in between. Your recerts, clarification orders, which you're right. I get into a debate if they're completely required or not. I say everyone should write clarification orders. It's a really good way to prove your physician's involvement with your cases. If something comes up wrong with these certs. Are your daily notes there, your encounter notes? Are they covering the therapist's skill and not just what the therapist did? Or, just what the patient did? Is it covering your therapist's involvement and your therapist's skill? It should be. Group, is if there was group involved, which we haven't been doing with a lot of the COVID stuff, but if there was group or concurrent, is it at that 25% or less threshold? Or was it over? Beneficiary notices, again, are those being issued? Basically, that's what that comes down to. Are you guys getting them out in time? We went over that. If something changes, are they being notified? We notify the days remaining. Okay, and we're the appeal process followed, and appropriate. Okay, back to validating some of the case mix for nursing. These are some of the additional things that you'd want to think about. But if they qualify for behavioral symptoms and cognitive impairment or reduced physical function with the restorative end split, is all the restorative documentation and the requirements in place. Okay. So, if someone has reduced, this is one of the things we do. We train restorative programs, put them in place. There is a requirement for training of those people that you have to meet. And there is a requirement of days of delivery. That has to be done 6 to 7 days before you get that end split. Even though there's going to be you get the 2 programs, are all the other all the other requirements met, including the training. That really, even though restorative isn't skilled, that's kind of a skilled service because you have oversight of a clinician and they're delivering at certain days under a certain plan, under a certain way, especially trained people. So there's a skilled component there, and you get that extra. You do get extra reimbursement now for that. Validate non-therapy ancillary case mix groups. All those things. 60-day, just like active diagnosis, has to be 60 days addressed or addressed by a physician, which the facility hospital documentation you guys receive should cover that pretty well. But is it being treated or affecting the patient in the last 7 days? Okay. Identify clinical service condition which qualified for points and verify that they're in the medical record. Very important. Special care high, special care low, all those things. Make sure the skill's still there. And PHQ-9, that adds to it for that depression end split, depression additional add-on, whatever you want to call it. Is that being done accurately? Is it accurate? Is it in the chart? Was it done within the window? Is that process working for us? Are we seeing a lot of depressive patients, we feel, not participating in therapy, not eating, not saying they're not happy, not sleeping at night, and we're still coming out with perfect PHQ-9s? Maybe we need to look at that process. We seem to be missing some of our depression patients. And even though that can affect quality measures a little bit, again, accuracy, guys, that is the key. If you have a lot of depressed people, so what? You just do. That's what they have. It's not really your fault. That I know that kind of reflects that way. But if you are meeting the needs of all your residents, that's what you want to be. That's the facility you want to be. All right. So those were the ACE things we covered, and I have some resources you guys can use for that. I don't expect you to remember all that, of course, but we have some forms you can use that will actually cue you, and it's a yes or no too, guys. I wouldn't have big forms with big paragraphs written after about all this. Hey, is it there or not? That's it. And if it isn't, why? That's really all you got to know, because you should be expecting things to be there. This may not be the time to write big notes and charting notes and big explanations for things. There really isn't, because it doesn't matter. It's either there or it isn't. All right. And we got to find out a way to get it there. So that's really all these forms should be, yes or no. Now, just want to touch on Part B, because Part B is very important. Part B is very highly scrutinized in our industry, especially as therapists. I've been through this before. So if you do want to flip this over to check some of your Part B claims, I think it's a great idea and you should do it. And I know this was about PDPM, but I felt bad not going all the way through this and not touching on it, because Part B is so important to both our residents, to both our, to the facility and the liability it could bring. Are you guys able to do that? So if you are going to do that, make sure you have those MD orders and they're signed by the doctor. Make sure you have the plan of care signed by that physician. Remember, Part B claims for your therapy teams, they're kind of independent. There is no cert. There is no hospital documentation. It's basically the therapist picking them up and getting the stuff from the docs themselves. If you don't have that stuff in place, man, that's going to be a denial. You definitely got to prove doctors' involvement with Part Bs, and I would definitely be writing clarification orders for Part Bs. I just would. There's nothing else. There's no safety net. You lose a cert or it doesn't get to the doctor and signed in time, you could lose that whole claim. But if you have that clarification order that will prove doctor involvement, I don't know, just think, I would do it. Most places do it. Those of you who aren't, I would think about it. I think it's still important and relevant. Dates of service accurate. Does it match the grids? Are the units matching? Totals. Okay, CPT codes. Do they add up? Are they, this is actually have to do with the MDS. There's a little piece in there from the MDS, so I won't talk about that. But the 25% threshold, are they doing group with Part Bs? Because they shouldn't be. Are they doing concurrent? They shouldn't be. Make sure they're doing that. Are your modifiers accurate? They still have the KX modifier, guys. You still got to put it on there. Even though the exception process has been repealed, the modifier is still there. Are they using the 59 modifiers? Are they using the therapy assistant modifiers? You have to do these. You have to use these things now. And if they're not being put in there, it puts you up for liability. Okay. And again, it's really only up to your interactions with your therapy company, because these are Part B patients. There is nothing else. Your therapists are picking them up and generating the claim. There is no Part A side of it through nursing and the hospital and these other certs and all these other things that you could. This is just therapy, man. This is really risky if you don't have your ducks in a row. And these are pretty big billers for your facilities. So you want to make sure that you're getting. I know facilities do 200 Part B units a day. It's a lot of money getting billed. Is your MPI number correct? All your what am I trying to say? All your demographic stuff is the date of birth, is the resident's name. Now, again, don't have all these other things to fall back on. We don't have these billing items coming from the hospital, the billing department, the old claims, the orthopedic surgeon stuff to verify it with. No, this is just you putting it on there yourself from your therapy team and sending it in. That stuff has to be right, and make sure that stuff is always there. So just wanted to cover that really quickly. The rest of the stuff has to do with some forms, which the business office would probably be handling. We don't have to really get into that, but it's more about how the claim is processed. But I'm more just talking about, like, really quickly, clinically, Part B's, the nuts and bolts of what can get you in trouble if you don't have these pieces in place. So, I'm going to sum up really quick. Get your evals done and signed on time. Write clarification orders. I would just do it. Make sure it's billed accurately with your CPT units, and make sure it's just not overutilized. You don't want some of your Part B claims going for 6 months. I'm telling you, it's a bad idea. It's going to be very hard to prove your skill for that long of a time. Very hard to show progress that long of the time. Not that progress is the only way you need a skill, but things to think about. Make sure that your delivery to your Part B patients is very accurate, very objective, that they're using objective testing to make sure that all your you show good progress. You show why it's important when you use the objective tests. Why are you guys really doing this, man? Why are you guys having somebody in here lift a cane, 50 times a day? Or why are you having them reach for cones? What are you getting at? What are you getting at? So have objective tests, have ADL goals. You'd be shocked how many evals I see from therapists, OTs, of course, that don't have ADL goals at all. I'm like, really? No ADL goals at all, man? Are you kidding me? This person, why did you pick them up then? These things are supposed to be important to the resident to take care of themselves functionally. You have to have ADL goals and make sure they're doing ADL sessions. Part Bs can be a really, really big liability, and people get very lax sometimes. And they think they're not as important as the A's because they're not going home. No, they're just as important. And guess what? Your denials will come faster for Bs than they will for A's. You got to really make sure you're pinpointing your needs when you treat Part Bs, and you're pinpointing your skill as a therapist on a Part B claim. You better be saying what you're doing as a therapist and not just what the patient's doing for exercises. It's not going to work very long for a Part B. Part A's, you have other things to fall on there sometimes. And sometimes it is easier because something happened to them. They had a hip replacement. They fell and got hurt. They had a brain aneurysm, a CV. Very clear. Someone's just declining in a facility and get a referral. I think sometimes we don't do a very good job both on our evals either. Sometimes our evals have to be more comprehensive, but also our claims and our treatments, we have to prove our skill a little bit better. Fall lacking on that, okay? All right, so, hey, that's it for the instruction piece. Here's just some quick resources for you guys that I kind of put together. Here's I have a UB04 submissions, a claim submission guide. It goes through every field locator, every description of what should be in that locator for both an outpatient and inpatient claim. Remember, a UB04 is used by a SNF for both inpatient consolidated billing and outpatient Part B. For outpatient clinics, they use the 1500 form, which is only for outpatient B services. In SNFs, we use the UB04 because you're billing for both. But it depends on the claim. Sometimes you'll have different ways they look. This is an example of a UB04 and how it looks and kind of how it's set up. Our next resources are going to be our triple check form. Again, it's a yes or no, guys. You either have it or you don't. Check it off, get it done, and make sure it's there. And if it isn't, have a conversation and have a better place. Then you'd write it up in your QAPI improvement program. But for your triple checklist, this is what you should be going through and making sure those things are there. And eventually, the hope is you would just go boom, 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 and they'll all be there. You wouldn't have to really, you wouldn't need many notes. But for your initial triple check process, is it there or is it not? What ones aren't checked off and what ones do we need to work with? And then on the back of that, I did put some of these field locators just to help you guys where to find stuff is, some revenue codes for certain disciplines and certain procedures, some occurrence stuff, some treatment authorization codes, so just the most more common ones that you're going to see in our setting, long-term care. So that may be helpful. And hopefully that will be a little bit of a guide. And hey, man, you can use whatever form you want. There's all kinds of forms out there. Briggs makes some. MedPass makes tons of versions of forms, but they're basically the same stuff. You're just going through the process of making sure it's all there and giving that yes or no on if it's there. All right. So when we look at this UB04, I just want to show you this really quickly. As I touched on this earlier, but I just wanted to make sure that you kind of understood what those field locators are. You have all these individual items on there where you actually can see the 1s and the 5s, like any hospital. I don't know where that came from. But that was field locator 1, 2, and then if you go down to 10, birth date, 11, sex, and then and so on. So if you look at that form, both the submission, I can't remember what I called it, that guidance form for the UB04 submission, how to do that. That's what those field locators are, especially on the back of the checkoff sheet for your checklist for your triple check meeting. That's what, good way to find those and look at the descriptions and all the revenue codes and service dates and all those things. So little idea on how that looks and how that works. And anyway, that's it, man. So I hope you enjoy this. I hope it's helpful. If you ever need any more assistance or any more help with any of these items, feel free to give us a jingle. Phone number again, 1-801-PDPM-PRO, or hit our website at www.pdpmpro.com and send us a request just for some more information. We would gladly assist you in whatever you need for these services and any others. So anyway, that's it. Thank you for attending. And again, any questions, please let me know through that email. All right, that's it, guys. Take care.